Tom join us?
Yep, we do. We do have Tom Contrucci with us today as a guest lecturer. Thanks, Tom, in advance for joining us. Tom is with the health system here at the U of M, where he's the director of supply chain strategy and procurement, and he's going to talk a little bit about medical device purchasing. So I will switch us over to Tom's presentation, and then Tom, I will make you a presenter, and you can have full control. All right, Tom. I'm going to go ahead and unmute you, Tom, so we can hear you.
I'm here. Can you hear me?
We can. Thank you.
All right. Well, thanks for the opportunity. I spoke with Jonathan this past week, and he just asked that I give an overview on some of the procurement policies, procedures, and the landscape. So I'll, for the sake of time, I'll clip through these slides as quickly as I can, and if you have questions at the end, then feel free to ask them. So Jonathan asked that I just give some overview of the landscape, and I just want to touch base on some of the organizations that are out there that vendors and manufacturers would be dealing with. We have these large academic medical centers like the University of Michigan, Duke. There's public organizations like ourselves, and then there's private organizations like Duke. They operate basically the same, but organizations that are publicly funded are open to Freedom of Information Act type of regulations, where academic medical centers like Duke are not. Some of the large Catholic health system organizations out there, like Ascension, are fairly big, with 35 hospitals. They operate, and I'll talk a little bit about this on the next slide, in a centralized purchasing environment. You have your large independent regional medical centers like the Henry Fords of the world and the Beaumonts. Again, their purchasing is centralized. And then what you're seeing on the landscape, these joint ventures that are forming, like Catholic Healthcare East and Trinity, that'll bring together about 75 hospitals under that joint venture between those two. A lot of buying power, a lot of influence in the market. And then you have the for-profits out there like Tenet. Tenet, I believe, has about 80 hospitals in their systems, and again, operate a little differently, really strictly from, as more of the health systems are focusing on bottom line, they're very, very bottom line, and they operate from a profit margin. And then you have the smaller community-based hospitals, which are becoming a thing of the past. In Michigan, there's Crittenden. I think if you've been watching the news, Botsford and Oakwood are most likely going to go and align themselves and become part of the Beaumont system. Mid-Michigan is a community-based hospital that we have an affiliation with out of Mid-Michigan, and it's a 4-hospital community-based system up there. Next slide. Go down. Why is my deck isn't moving? All right, sorry. This slide talks, for the most part, about that most organizations have on-site purchasing departments. I think you're seeing some of the larger systems that are transitioning more to a centralized model. I know that Trinity and Ascension are going to be doing corporate purchasing out of their central offices. You're seeing the Beaumonts and the Henry Fords of the world also do centralized purchasing for their health systems and hospitals throughout their locations. Most public organizations, you'll need to know this when you go out, at least to the public organizations, they have bidding thresholds. At the University of Michigan, our bidding threshold is $5,000. That's under review to raise that a bit to $10,000. But that requires that any requests that come through the procurement office either have a competitive bid or there's justification from the department, the physician, the clinician to sole source that product. The timeline to gain approval for introduction, it varies widely. I'll share in a couple slides our timeline as it relates to new product introduction in a couple slides down the road. Just want to talk a little bit about the role of the group purchasing organizations. GPOs are entities to aggregate spend amongst their members in return for more favorable pricing. Some of the major GPOs that are out there in the industry are University Healthcare Consortium, that's UHC, VHA, and Novation. The University of Michigan, is a member of Novation. Premier is another major GPO out there, and so is MedAssets. Pricing, for the most part, through GPOs are quite similar. I've had experience working with Premier and Novation. They're basically tiered pricing agreements, and they're based on purchasing commitments. Some of the manufacturers that have wide scopes of product categories, like a Baxter that has infusion pumps and IV solutions and IV sets, the more products that you buy from those various divisions, the more favorable your pricing and the higher tier that you get to. So that's something that manufacturers are looking to do when they go to contract with GPO. GPOs, for the most part, are funded through administrative fees that are paid by manufacturers. So manufacturers, again, will contract. They'll pay the GPO an administration fee. The members do get a portion of that back in the form of a rebate. We do have to report that on our annual cost reports as a reduction or a discount in pricing on our cost reports. There's a lot of regulation related to GPOs for anti-kickback statutes and things of that nature. Their product contract portfolios could include, medical surgical commodities, pharmaceuticals, physician preference items like implants, capital equipment, food, janitorial, etc. I will tell you that GPOs are not necessarily very competitive when it comes to the physician preference items. And most hospitals, whether they be academic medical centers or independent, do self-contracting for those. We team up with our physicians here and go to the market and negotiate with the various manufacturers out there for orthopedic implants, cardiac rhythmic management implants, neural implants, etc. They do offer, so GPOs do offer group buys to their memberships at times. So, for instance, we participated in a group buy for ultrasound equipment this past year, and it's where various members can come bring more volume to the table on the capital equipment side in return for better pricing. Some examples of how GPOs are used. Some organizations use them exclusively. The organization that I worked for 10 years ago, their directive was get to the highest level of the tier and do what you have to do to get there. Some use GPOs contracts as a supplement to their contracts. We use Novation primarily here for medical surgical. We self-contract for all of our pharmaceutical items here. Some academic medical centers like Duke, they don't belong to any GPOs. They just strictly do self-contracting for both med-surg, capital, pharmaceuticals, etc. You're starting to see a change in the landscape here with the formation of regional collaborations. These are efforts where hospitals within group purchasing organizations come together and form regional collaborations. We're in the process of doing that right now with our affiliate up in mid-Michigan in the beginning stages of that. And the thought behind this is that we go and we come together and we try to standardize products, whether that's distribution services or implants or needles and syringes. And we then go back to our physicians and clinicians and say, we as a group, we want to commit to this. It's a committed volume contract. And when we go out to the marketplace, vendors are very interested in committed volume contracts. One of the problems with GPOs is that you don't necessarily have to commit volume. Therefore, manufacturers are out there looking for organizations that are more willing to commit. Novation right now has at least 4 regional collaboratives that they're working with. And so we're in the process of doing that as we gain other affiliations and look to other organizations to become part of the University of Michigan, whether that's Allegiance Health in Jackson or what that may be down the line. And then some health systems are moving to self-distribution models, and where they're not only dealing directly with the manufacturers, but they're building warehouses to bring product in. An example of that, I know Beaumont is doing that right now. University of Pittsburgh Medical Center also does that, and they do their self-contracting. I'm going to talk a little bit about vendor interaction and visitation policies. Most health systems have specific vendor visitation policies that really outline how vendors are to conduct business at that organization. That second bullet on slide 4, I've listed our vendor visitation policy there. If you go to the University of Michigan Health System's internal homepage and just click on the link for compliance forms and procedures, and then click on the link for UMHS policies and procedures, and search on that policy number, our policy will come up. So you'll kind of get an idea of the various, of a type of vendor visitation policy. It's quite similar to what is out there in the marketplace. There are CMS regulatory requirements. CMS is Centers for Medicare and Medicaid Services for the health systems to ensure that vendors that and their representatives have not been excluded or debarred from government agencies like the Office of Inspector General or the General Services Accounting Administration. So we're required to ensure that either vendor reps or the vendor themselves are not on those lists. That's done through that next bullet, through a vendor credentialing system. So we contract with a provider called VendorMate. As vendors come to do business here, we register the vendor, we register the representatives, and we have different categories of risk that we've assigned. So representatives that are in the OR supporting cases are of higher risk. We do a much more thorough investigation of them. All of them are subject to the debarred and excluded evaluation process. We also require that if vendors are in those areas that they have their immunization, and we keep track of those records, whether it's flu or hepatitis or whatever it may be. That last bullet on slide 4 talks about new regulatory requirements. The Open Payment, or also known as the Sunshine Act, went into effect last August, and this rule requires that the industry to disclose to CMS any payments or what they call transfers of values to teaching hospitals and physicians. Examples of that would be grants, gifts in kind, consulting payments valued at those dollar thresholds mentioned on the slide. I can tell you we've received our first report from CMS, and can tell you we've gotten a few calls from physicians whose name has shown up on that report, and so there's much more public scrutiny as to how vendors are doing business and how they are supporting health systems and passing on transfers of value. Slide 5. This really gets into, in slide 5 and 6, I know Jonathan had asked that I give a high-level overview, and this may be a subject for another session down the road, but I thought I would just touch base on our value analysis and product introduction. So you'll find as you do business out there, most if not all health systems right now, in particular the large independents, the major academic medical centers, the Catholic Healthcare East, the Ascensions, have a value analysis team, and their role is, as is outlined there on that slide, they're primarily that link between you, the manufacturer, the clinician, and the procurement staff. That function reports to me directly. I have a nurse that is the director of value analysis, so she's clinically trained, clinically based, and she's able to bridge the business side and the clinical side in a very nice way. The use of detailed new product requests, I'll get to that on the next slide. I just threw in there our process flow for how new products are introduced, so you can see the process that we use at Michigan and the associated timeline. Value analysis also spends a lot of time working and monitoring FDA recalls. In the event that there are recalls and or supply disruptions, they facilitate product substitution and work with our manufacturers to do that. They do a lot of research and investigation on clinical studies. I was sitting in on the previous presentation, and I think Jonathan mentioned outcomes. I'll tell you, it's huge in the decision-making process. So we are looking for outcomes. We're looking for clinical research and data that supports the product. And if you're making claims about that product, we want to see the research. So this value analysis team does a lot of research, and they bring that to the table as they prepare reports for physicians and clinicians. They facilitate product evaluations, and they facilitate a process of in-service education if that's required. Slide 6, again, you can zoom in on that. I think this thing might help us zoom in a little bit on that. The intent here was just to kind of give you a bit of an overview of our new product introduction process here. Over in the right-hand margin is the timeline for the various activities associated with bringing a new product into the system. So you can see if everything flows right and we do all this analysis, it can sometimes take up to 50 days to get a product introduced and put into our item master within the organization. And I know we were limited at time, but I thought I would just share this flow with you. And if this is of interest to you, we may be able to really bring our Director of Value Analysis and do a session just centered on this down the road. Jonathan asked for who are the key decision makers. Obviously, physicians and clinicians, key business leaders like senior leadership, clinical department administrators, finance, contracting and procurement and value analysis. I can't stress enough the importance of manufacturers building a relationship with contracts and procurement and value analysis. You can do all the work you want with the clinicians, the physicians, but we're still the people who have to sign the contracts. We're still the people that have to write up the justification, do the financial analysis on this. So you're better off engaging us up front than at the middle or the end of the process, because I'm going to tell you, if you do that, it'll add a significant amount of time to the process. Infection control is involved in a lot of what we do. When it comes to capital equipment, we look at a lot of either capital leasing or fair market value leasing. All of our capital equipment has NPV analysis tied to it, so we look to see what is the best option financially for us. Legal and compliance, BAA stand for Business Associate Agreements, conflict of interest. I talked a little bit about excluded vendors and vendor visitation, but we work quite a bit with legal and compliance. And then lastly, a biomedical engineer is involved in any product that is related with patient use in this organization. There are a lot of joint commission requirements to ensure that the products coming into the organization have been tested properly. So if we get infusion pumps into the organization, they have to go through a biomedical check-in. They enter that equipment into their logs for maintaining preventative maintenance and just overall product maintenance. So this last slide, and I think I'm keeping it till about 4:30. Jonathan asked, what about associated questions? And I'm going to tell you, this is, I probably flipped this around a little bit, because as you present products into this organization, whether it's here, Beaumont, Ford, or wherever, you're going to get asked these questions, and you should be prepared to answer them. So what are the clinical studies that support your product or device? That second bullet, I know you guys talked about it. How will this product improve outcomes in patient care? How will this product or device reduce length of stay? There's a lot of pressure on moving patients through the system in an efficient way. And I think if you can bring products to the table that demonstrate that, you're going to move to the head of the list. What are the key? Safety is a big deal. We just did infusion pumps here last year. Alarms, the ability to respond to those, to hear them, to discern them by those clinicians is extremely important. Additional services and preventative maintenance. We view things from a total cost of ownership. It's not just the product cost of the device, but what are the service costs? What are the freight costs? What about the payment cost? And how do we handle really the total cost of ownership? And then you will definitely want to set up a time with procurement and value analysis director just to go over the process. And I think if you're able to do that, it will greatly help you introduce new products into any healthcare organization that you work through. So I blew through this rather quickly to respect everybody's time, and I don't know if there's any questions, Jonathan, or how you want to handle this.
Well, Tom, if you have time, we can certainly take a few Q&A. Does anyone want to ask a question of Tom? Just unmute yourself and let it rip. All right. If there are no questions, I'd really like to thank Tom for taking the time to talk about this. I think that a lot of the takeaways are that, boy, there are a lot of people you got to talk to. There's a lot of different parts of the purchasing process you need to understand to really know how you're going to deliver value both to yourself and to the healthcare system. So I think Tom did a great job of kind of pulling that out. So I'd really like to thank Tom again for his time.
I have a quick question.
Sure, please.
So Tom, you had mentioned a whole bunch of different people that you have to talk to in order to go through this. Where do you start? Like, who's the first person that you start with? You know, like when you have a new product.
So I would suggest that you start with the director of value analysis.
Okay.
That flow that I put on there, we have an electronic way to which anybody can request a new product into the organization. And that goes right to the Director of Value Analysis staff. So if you start there, she can help navigate you through this entire system here. What she does is she links the clinician, the physician, contracting people, the financing people, and as she brings the contracting people in, the contracting people bring the legal people into the equation. Where we find ourselves spending a lot of time is on the legal side, and just negotiating terms and conditions. So if you start with the value analysis person, she can be the key person to link you to everybody. And she's really done a great job here. We have great relationships with our physicians and our clinicians here. So that's my recommendation, is where you should start.
So do most of the purchasing groups that you mentioned, do they all have a person in that equivalent position in the value analysis director?
Yeah, I would say most academic medical centers all have them. I mean, UHC has a whole value analysis program and team and support mechanism. I know the Henry Fords of the world, the Beaumonts of the world, the DMCs have them. The smaller community hospitals may not be as sophisticated and have the resources there. I know we're working with Mid-Michigan to get them up and running on a value analysis program. But value analysis has been around in industry since, the 1940s. So we just stole that concept and really kind of brought it into the health system. So that's where I would suggest you start. And yes, most academic and health systems have value analysis people.
So, and I have one more question, if you have time. So how amenable are universities to adopting new tech or new devices compared to other institutions? Like, if you had a new piece of tech, where would you start? Would you start with a university and an academic center? Would you start, in another place?
So I would, academic medical centers have a lot of individuals here. A lot of our physicians are already involved with manufacturers in the development of products or the consultation of developing products. They have to disclose, their interest when they do that. But I would suggest that, academic medical centers are probably very good organizations to start to develop concepts and new products. We do not prohibit manufacturers or reps for setting up appointments with physicians or clinicians without going through our office. If you read that vendor visitation policy, if you get a chance, it really goes over, how you go about doing that. My reason for telling you to go to value analysis first is because it's going to have to come to us sooner or later. And if you engage us up front, we can work with that physician and the manufacturer. So I think the academic medical centers, I think the Henry Fords and the Beaumonts of the world, and the Detroit Medical Centers of the world are all great environments for which you to to bring products. I mean, if you look at Beaumont's advertisements, I mean, they talk about developing knees and all kinds of components up there. So I hope that answers your question.